And this is in continuation of the prepping up for the community medicine practical examination, and I will be dealing the problem cards in continuation in the second part, taking up some newer problems which are important. As you already know that the community medicine practical has a certain format as given by the National Medical Council. Problem card of that consists of 10 marks from the allotted 40 marks of practical. Before we embark on the journey, don't forget to subscribe to the channel. It's completely free, but it definitely boosts up the channel morale. So, do like, comment, share and subscribe, and here we go with the content. The first question we are going to deal with it runs, a patient has come to you with a dog bite at a left cuff muscle. On examination, there was an abrasion without oozing of blood. What is the category of bite and how will you manage the case? See, this particular question is just a tentative picture. You know how the question might look like. It is not necessary there is the only type or it's just a prototype. In this particular problem card, the mentioned bite belongs to category 2 of bite. Now, as you can understand, this is from the chapter of rabies, and it is very important to know, supposing the bite is given differently, the bite is given such that there are multiple wounds, the patient comes to you with multiple wounds, the patient comes to you with oozing of blood. So the issues can be different. So it is, as I always emphasize upon, that don't prepare yourself for a particular type. You always should be preparing yourself in such a manner that whatever combinations or permutations comes from that particular area, you will be able to handle that. So taking this as an example, but giving you a deco into how to handle any of this or how to categorize if there is any other picture given regarding this canine bite. So it can be good to know the different categories, what are the post-exposure prophylaxis recommended for each of these categories. And let me tell you, if in case of a rabid dog exposure causing no injury to the skin in continuity, that is intact skin, then it is called a category 1 and no vaccines are required. But if there are minor scratches but with no oozing of blood, just as it matches this particular problem card description, then it belongs to the category 2. Then you have to go for the rabies vaccination apart from the certain other care. And if there is transdermal bite, the skin is wounded, there is oozing of blood, there are multiple wounds, there is even a single wound on the danger areas like the face, then it belongs to the category 3. And in that category 3, along with washing the area, the vaccination, it is also important to infiltrate the wound area with this immunoglobulin. So let's look about the management. The post-exposure prophylaxis of PEP, that is popularly known as, is the administration of the rabies vaccine with or without the rabies immunoglobulin, just as we mentioned earlier, depending on the type of exposure category. And the first thing that includes is wound washing and wound care. The wounds to be washed immediately with soap or detergent and flush them thoroughly for about 15 minutes with copious amounts of water. If soap is not available, flush with water alone, but do it. Wound washing is the most effective first aid treatment against rabies. And then apply iodine containing or antiviral medication preparation on the top of the wound 15 minutes after it has been washed and flushed. and take the person to a nearby healthcare facility for further assessment and treatment by a healthcare professional as soon as possible. And the biting animal should be safely confined for a period of 10 days where possible, and collect the information on it and the bite circumstances to provide information to the healthcare professional and public health officer. And the PEP sometimes includes the administration of rabies immunoglobulin or RIG depending on the severity of the exposure, which we all discussed. So this is basically the WHO recommended PEP, that's Vitone, exposure, wash immediately for 15 minutes with soap, water and disinfectant, and vaccines to be given in this particular problem cut description. No immunoglobulin because the severity isn't of that degree. And what is the vaccine schedule to be maintained? If it is given IM, then SM regime is followed. It's a 5-dose regime that prescribes 1 dose on each of the days, 0, 3, 7, 14 and 28. And it is usually given into the deltoid or anterolateral part of the thigh. The Zareb regime is also given. It is actually a 4-dose abbreviated multi-site regime which prescribes 2 doses on day 0, 1 in each side of the deltoid or thigh sides, followed by 1 dose on each day 7 and 21 as shown in the diagram. If it is given intradermal, the dosage is obviously much less, actually 1/5 of the intramuscular dose, that is 0.1 ml per site, and the 2-site regime prescribes injection of 0.1 ml at 2 sides, either deltoid or the anterolateral part of the thigh on days 0, 3, 7 and 28. Here the day 14 dose is not given. It is also good to know the post-exposure prophylaxis for the previously vaccinated individuals because the card might read that the person was previously vaccinated. So for rabies exposed patients who can document previous complete pre-exposure vaccination or complete post-exposure prophylaxis with a CCEEV, that is the cell culture egg-based vaccine, 1 dose delivered intramuscularly or CVV delivered intradermally on days 0 and 3 is sufficient. So after this, dog bite, let's come to the another clinical picture given for problems commonly. A patient has a complaint of low-grade fever, weight loss, anorexia, persistent cough for last 1 month. On examination, sputum smear was positive for AFB. After starting treatment, he stopped medication for 2 consecutive months. How will you manage the case? And what category of treatment will you allot to him? Describe the regime. Well, as you can understand, based on the clinical findings, this belongs to a case of tuberculosis that has been previously treated, that is to the category 2. Earlier there were several classifications, but currently only 2 categories are mentioned in tuberculosis. There is the new category and the previously treated category. And the treatment regime in the new category is, intensive phase of 2 months and treatment phase of 4 months in the continuation phase. The intensive phase consists of 4-drug regime of INH, rifampicin, pyrazinamide and ethunamide, and the continuation phase consists of 3-drug regime, that is INH, rifampicin and ethambutol. And in the previously treated category, which is applicable in this particular problem card, the 2 months of 5-drug regime, that is INH, rifampicin, pyrazinamide, ethambutol, streptomycin, and 1 month of 4-drug regime. And the continuation phase is for 5 months of 3-drug regime of INH, rifampicin and ethambutol. The daily dose regime for adult tuberculosis, it varies according to the weight category. And as you can see here, I mentioned the number of tablets to be taken because usually the blister packs are given. and accordingly the patient needs to take. So in patient more than 50 years of age, the maximum dose of injection streptomycin is 0.75 gram and no extension of the intensive phases. The extension of the continuation phase may be done by 12 to 24 weeks in case of central nervous system, skeletal or disseminated TB based on the clinician's decision. Problem card reads of a patient of the pediatric age group. Then again the dosage schedule for pediatric tuberculosis management will vary according to the weight category, which you can see here, depending on the intensive phase as well as the continuation phase. And then in that circumstances you have to mention these revised doses. Now let's come to another situation. This is again related to one of the important aspects of this community medicine, that is immunization and cold chain for maintaining the vaccine states. And this particular card reads, in a PHC, after opening the ILR, the ANM notices that there is 2 inches layer of ice in the inner wall. What the ANM should do, what consequences will happen if the ANM doesn't do anything, and what should be done with the vaccines, and write down the 6 precautions that are to be taken during the storage of vaccines in the ILR. So let's see. So for this, you need to know certain things. You need to know the immunization schedule. You need to know the cold chain equipments. You need to know the precautions that are necessary for maintaining the cold chain equipment in a proper fashion, and also which are the heat sensitive vaccine, which are the cold freeze sensitive vaccine, so that according to those inputs, you can arrange your answer. First of all, you should be knowing the order of storing the NIS vaccine in an ILR. That is, the NIS stands for the National Immunization Schedule and the ILR stands for the ice-lined refrigerator. Well, the bivalent OPV vials are to be kept at the bottom of the basket. The MCV, that is the measles containing vaccine vials, are then laid out over the bivalent OPV vials, and other vaccines are stored next. That is in the upper part of the basket in the following order. First the BCG and JE, then the rotavirus vaccine, the TTs, the DPT and IPV, the pentavalent vaccine, the hepatitis B, and absolutely on top, usually the diluents are kept. So what the ANM needs to do? The ANM needs to place a thermometer among the vaccines in the basket to see the present temperature. Since there is ice formation, the defrosting is necessary, so she has to defrost immediately and continue doing it periodically, and make sure that all vaccines are stored at an ambient temperature of 2 to 8 degrees Celsius. And at the same time, because of that ice formation, she also needs to check for any cold damage, because in that ILR we had certain fridge sensitive vaccines as well, like the hepatitis B, DPT, DT, TT or the pentavalent vaccines, which should not be frozen. So this is the group of vaccine that she should be checking for cold damage, because they lose their potency if frozen. And once the checking is done, which is usually done by undertaking the shake test, the suspected vial is shaked and watched for any flocule formation, or to see that if there is any movement of any fluid formation, or it's totally frozen. And if these vaccines are frozen or there is flocules after shaking, that is the shake test is positive, then these vaccines she needs to discard, and she has to rearrange, keep the fridge sensitive vaccines at the top and check for the vaccine vial monitors as well, and heat sensitive vaccines at the bottom. And besides this, she needs to keep all these particularly fridge-sensitive vaccines, in a plastic bag and place it inside a basket till the time within a vaccine carrier, so that till the time the ILR is defrosted and doesn't reach the required temperature, these vaccines are well protected. And the vials of pentavalent, DPT, DT, TT and hepatitis B should never be placed in direct contact with the frozen ice packs. So what are the precautions the ANM needs to exercise? Well, the 6 precautions is keeping the ILR in a cool room and 10 centimeter away from the wall. Keep the ILR leveled and use voltage stabilizer. Keep space between stacks on vaccines for flow of air. Keep the ILR locked and open only when necessary. Defrost periodically and supervise the temperature record daily. Place the vaccines as per the temperature sensitivity. Here you get a visual impression that how usually the vaccines are kept. In case the ANM is unable to get hold of a basket, what she can do, she can keep those empty ice packs, 2 layers of it, and then place these vaccines on top of it. Let's look at another problem card. It is again in the clinical presentation scenario. A 20-year-old patient from rural Bengal has come to a fever clinic with a complaint of fever with chills and rigor for last 4 days. After examination of peripheral blood smear, Plasmodium falciparum has been found. How will you manage this case? Well, here you have to say the diagnosis of Plasmodium falciparum malaria. So based on the age group, this regime has to be mentioned on your part, that the pink blister, the yellow blister, the green blister and the red blister depending on the age group. So 15 and above, you will be using the white blister. This colored coded blister packs are used for operational convenience at the grassroots level, so that the healthcare workers easily identify that okay, this is the blister pack for, if the particular patient reporting is around 13-year-old, they know that it's between the 9-14, they have to get the red blister. So the chance of giving the wrong dosage is largely taken care of. So you have to mention this age-based blister package schedule. And this is the scheduling depending on the age and weight of artemisinin-based combination therapy, which you have to understand and know. So if the diagnosis instead of falciparum read as Vivax, then of course the management you have to mention, apart from the symptomatic management, of chloroquine and primaquine, and mention the dosage and the duration as given here in this slide. In uncomplicated falciparum cases, as discussed, you have to mention the artemisinin-based combination therapy depending on the body weight and the age. If this was a case of malaria in pregnant women, that is this particular patient was mentioned as a pregnant woman, supposing the card read like that, then in that case you have to mention in the first trimester quinine salt 10 mg per kg 3 times daily for 7 days to be given, and from second and third trimester the artemisinin based combination therapy to be given as per the scheduled dosage. In case of mixed infection, that is both Vivax and falciparum, the full course of artemisinin-based combination therapy and primaquine to be given for a period of 14 days. There may be some card which might just read that it's a case of clinical malaria. That means where parasitological diagnosis is not available or still to be available. That is a suspected malaria case. It has to be treated with full course of chloroquine again till the results of microscopy is received, and when the parasitological diagnosis is available, then you have to go for the species specific treatment. That is why if it is Vivax, then you have to shift to Vivax management, or if it is falciparum, you have to shift to the artemisinin based combination. So in case of malaria and pregnancy, if the card reads so, then you have to mention that if it is Vivax, you have to go for chloroquine until delivery, no primaquine, but weekly 300 milligram chloroquine. And if it is a falciparum or a mixed one in pregnancy, then in first trimester, we are going to give quinine 10 milligram per kg TID plus clindamycin 10 milligram per kg BD, that is twice for 7 days. And in the second and third trimester, of course, we are going to go for the artemisinin based combination therapy. So we had a comprehensive look at some of the problem cards. This is again not exhaustive. There are several other problem cards which may come from any of the chapters that are in your syllabus. So be prepared for it. But this is how you should approach any problem card for that matter. Do not write in a lengthy fashion. Try to be objective. Try to write in bullets, and keep it as precise as possible. And when there are scenarios, you can use your flow charts, make it simple, use arrow diagrams. Most importantly is letting your examiner know the answer, and it is not important that you write pages covering it, because you have a very short time to cover epidemiological, statistical and problem card. So you have to optimize on time. You have to remember that, and all the very best. So get ready for your practicals. So if you do like the video and find it helpful, please do subscribe to my channel. It doesn't cost a penny, but it definitely goes a long way in making this channel more, reaching out to more and more students. So do like, share, comment and subscribe. So much. Happy studying.